The following podcast is part of a certified educational activity titled Patient-Centric Frameworks in Desmoid Tumors, Integrating Emerging Science on Gamma-Secretase Inhibitors for Progressive Disease. Access the entire activity and complete the post-test at peerview.com/NVF860. Downloadable slides and practice aids are also available.
So our goals for today are very simple. We want to enhance our knowledge of how to use gamma-secretase inhibitors for the management of desmoid tumors. We want to improve our skills for selecting personalized systemic treatment options that consider clinical trial evidence and recently published guidelines. And we want to equip you with strategies to address practical aspects of care, including shared decision-making and adverse event management that's so important whenever using newer drugs. Until today, there are still major gaps and challenges in the diagnosis and treatment of desmoid tumors. This is in part linked to the fact that desmoid tumors are rare conditions with a very variable clinical presentation, very variable clinical course and outcomes in individual patients. This can lead to issues with the actual diagnosis of desmoid fibromatosis. We see patients with initial misdiagnosis, which is not uncommon, and this is linked to the rarity of the disease and the fact that desmoid tumors can mimic histologically and clinically a series of other conditions such as soft tissue sarcomas, but even endometriosis, to give a few examples. The other thing that has caused a lot of problems in the recent past and until today is the fact that effective, safe and regulatory approved systemic therapies have been lacking for a long time. Luckily, we are moving in the right direction because we are seeing the few first randomized trials in this field which have a direct impact on how we treat these patients. I don't think I have to go into the details of the biology of this disease. We know that desmoid tumors can develop as a result of a CTNNB1 or mutations or APC loss, and these two genetic changes can lead to the development of this disease. And what you all know is that the Wnt signaling pathway is critically involved in the pathogenesis of this disease. In the past, we have treated desmoid fibromatosis primarily with surgery. We have learned the hard way that this is not always the right approach. This is a series published in 1999, where about 30% of patients who underwent surgery for desmoid fibromatosis actually relapsed. But this didn't have a major impact on the survival of these patients, luckily. In other series, we have seen relapse rates of up to 50% of surgically treated patients. And this has led to some guidelines out there that suggest that surgery should no longer be the primary treatment for localized desmoid tumors in typical cases. There are a few exceptions that we can cover later on. And some of this evolution in the treatment approach is manifesting itself in a number of guidelines that we have recently seen. I think this is the most important one, a guideline published in the European Journal of Cancer in 2020, where you see that surgery is only proposed for a subset of patients, for example, for patients with abdominal wall desmoid tumors, while medical treatments and other interventions seem to play an increasing role. You can download some practice aid based on what you see here on the scan and which you also find in the resources that we provide electronically. When you try to summarize the past, present and future treatment options for desmoid tumors, you end up with a very chaotic scenario. In the past, we used multiple interventions, multiple drugs, a lot of surgery, a lot of radiotherapy. I did a survey among 40 European oncologists treating this disease in 2018 and asked them for their preferred systemic treatment options, and they responded that they were using 40 to 50 different drugs for this disease. Luckily, we are moving into the direction of more randomized prospective evidence So things are getting clearer, but some of these drugs are still heavily used, especially in countries where gamma-secretase inhibitors are not yet available. What we also see is that some new emerging treatment options show up, especially ablative techniques for some patients, and there's also some kind of renaissance for some radiotherapeutic options. Tyrosine kinase inhibitors and gamma-secretase inhibitors are now dominating the systemic treatment field. I want to provide a few resources that you and your patients can use when being confronted with a desmoid tumors. So please have a look at these multiple QR codes that can get you to home pages of the DTRF tumor patient registry, and you can see and find some videos that also provide some guidance. Another resource that I don't want to forget is, of course, everything that SARC is offering to the community of people taking care of patients with desmoid tumors, and again, a few links if you scan the QR codes. So what is the emerging evidence from the clinical trials that I was referring to? We have really managed to refine our toolbox over the past few years only, and I think there are two important trials that most of you here in the audience know very well, and many of you have been involved in these trials, I assume, especially the very first randomized trial that Münil Gounder published in the New England Journal in 2018. In this trial, patients were randomized for treatment with sorafenib versus placebo, and as you can see here, there was an impressive advantage in terms of progression-free survival in the group treated with the tyrosine kinase inhibitor as compared to placebo, with a median PFS not even reached in the group treated with sorafenib. This has had a major impact on how we are treating patients with this disease, as it was providing the very first reliable randomized evidence to us. We learned a lot of things from this trial, especially that the vast majority of patients with desmoid tumors have measurable shrinkage of their RECIST target lesions. But what we were also reminded by this trial is the fact that if you treat patients with placebo or you don't treat them, some of them will have impressive tumor shrinkage as well. Even objective responses according to RECIST are possible, as shown here on the left side. The next study that really changed our field was the so-called DEFI trial that was published more recently, which explored the use of the gamma-secretase inhibitor nirogacestat in desmoid tumors. And many of you will also be involved in programs with a competitor agent called varogesastat, which is still an investigational oral potent inhibitor of gamma-secretase that is not yet approved. This is the outline of the trial that led to the approval of nirogacestat for patients with progressive desmoid tumors. It was a randomized trial with 1-to-1 randomization, nirogacestat versus placebo. Patients progressing on placebo could cross over to the active compound. I think many of you have seen the data before, and the outcome was crystal clear. There was a statistically significant difference in terms of risk of disease progression comparing nirogacestat with placebo treatment, as nicely illustrated here on the Kaplan-Meier plot. What we also learned with this trial is that in virtually every predefined patient subset, the drug did better than placebo treatment. We learned that nirogacestat is effective in both sporadic and hereditary desmoid tumors, and across the long list of predefined patient subsets here, there was an advantage of this treatment. So very convincing data on this forest plot. Nirogacestat gives good volumetric effects in desmoid patients, and many of these patients achieve an objective response. Only a handful of the patients in this study treated with nirogacestat had measurable progression or increase in size of the RECIST target lesions, I should rather say, while in the placebo group, only a fragment or a fraction of the patients had spontaneous regression of the lesions, which is a well-known phenomenon in this disease, and results obviously look better in terms of objective response rate for the active treatment arm. Not to forget to mention that this study also explored a lot of quality of life endpoints, patient-reported outcomes, etc. In the interest of time, we can only show selected longitudinal measurements of certain quality of life domains and PRO outcomes. And as you can nicely see here, there was a major advantage when comparing active treatment with a gamma-secretase inhibitor with placebo treatment. Nirogacestat was found to have a manageable safety profile, also illustrated by the fact that a lot of patients remained on active treatment for long periods of time, some over years, and you will see a clinical example later on. And higher grade toxicities, grade 3, 4, according to CTC, were really limited to a few patients, with diarrhea as the most common higher grade adverse event with this drug. And with this, I will hand over to my dear colleague, Bree Wilkie from Colorado, for the second part of our little presentation. Thanks, Bree.
Thank you. All right, great. So I'm back again. So now we're going to talk a little bit about ongoing trials and future directions. What's next after this incredible data and this real revolution in desmoid treatment that Patrick just walked us through. So basically the study that you briefly referenced for varogacestat, also known as AL102, is known as the Ringside study, and this is currently going on now. So this is data and the study that was recently updated at ESMO last year. So I'm just going to walk you through this one for those of you who might not be as familiar. But this is a phase 2/3 study of AL102. You can see the criteria for inclusion, the primary endpoint of this initial part, which is the regimen selection or sort of picking the right dose, is safety, and then a secondary endpoint with efficacy as well. And then after that is completed and a dose is selected, we then go on to a double-blind placebo-controlled component with open label extension. So this is a very busy slide, but this is the poster from ESMO of last year presented by Bernd Kasper. And so what I'll just highlight here, again, this is on the initial, I think it's about 48 patients or so total, and then 42 in the intention to treat. Looking at the recommended dose 1.2 versus all patients and all doses. And the take home here is that we're seeing similar safety profiles with other gamma-secretase inhibitors. We're seeing deep responses with a response rate of up to 75% in the evaluable 1.2 milligram population. We're seeing improvements not only by RECIST, which we all know is problematic in desmoids, but also in tumor volume, and then T2 signal intensity. So again, I'll just reference a question that's coming in, talking about this percent of tumor color changing, like this process of going from an activated enhancing desmoid to a collagenized dead desmoid. And so this will play in here in our discussion. So the other study that's currently ongoing, which is another question that's coming in about treating adolescent patients. So is this effective for kids in adolescents with desmoid? Is it really the same disease, the same biology? And so this study has fully accrued. This is being run through COG, looking at nirogacestat in patients greater than 12 months and less than 18 years. Weight-based dosing of nirogacestat at 90 mg per meter squared. Again, with the primary endpoints of progression-free survival, response rate, safety, and so on. So eagerly looking forward to the data from this study. And I think, what's interesting, if you think about kids and adults, what's different? So you have a lot more growth hormones. You have a lot of patients who are actively going through hormonal changes, which we know are important in desmoid tumors. So just anecdotally, I had a 19-year-old on the main nirogacestat study, and he had some initial clinical benefit, but we never really saw that deep response. We never really saw a lot of evolution. And I have kids or sort of young adults who also are just kind of coming out of that hormone-robust period where, again, really this question of, are we going to see the same sort of benefit? How much active desmoid do you need to actually be able to respond? And is it going to hold up in kids and young adults? So take home, eagerly awaiting this data. So these are some of the unanswered questions, and I think people have referenced these in the questions, but I'm sure there are more. But so really, how long do we need to continue treatment in order to get durable disease control after response? When can you safely say we've reprogrammed the desmoid with nirogacestat or sorafenib for that matter, or Doxil chemotherapy historically that we used to use? We saw this phenomenon where you would start to see the tumor involuting or just plateauing with the growth and starting to turn the corner. And at least for my patients, we were able to stop treatment, and often the tumor would continue to respond, but we don't really know if that's the case with gamma-secretase inhibitors. Do you need active disease to actually get a response? The trial was limited to patients who had radiographic progression or newly diagnosed tumors. And there are patients who've been waiting for this drug to be available, in my clinic at least, for years, and they want to try it. But if they haven't met those criteria, are we still going to get activity? What happens if you have to interrupt the drug for toxicity? What are the mechanisms of resistance to therapy? And then we'll talk a bit about ovarian side effects. How does this affect offering this therapy to younger patients or timing for patients who want to get pregnant? Okay, and then I'll make a plug for this. So is there a future role for exploring gamma-secretase inhibitors in other diseases that are dependent on Notch signaling? And I just say this because I've seen probably 8 patients with keloids coming to my clinic for consideration of gamma-secretase inhibitors. This is not approved. This is totally off the wall. But the point is this disease is also very, very dependent on Notch signaling. And yes, normally with keloids, we can resect them, we can radiate them, we can inject them with steroids and things like that. But this is a patient that I saw who unfortunately had numerous stab wounds from a really traumatic incident earlier in her life. And literally all of her chest, extremities, neck are these massive keloids that were very itchy and burning and symptomatic. And as you can see in this prior paper from 2012, these keloids are loaded with Notch. So I think one area potentially to think about would be looking at gamma-secretase in these diseases. So now I'll sort of shift a little bit into patient cases and panel discussion. So stare at this photo. I'm sure you can all identify this famous landmark here for ASCO. Do you see it? Do you see it? So this is case 1. So this is Dr. Shofsky's patient from University Hospitals in Leuven. So I will just tell you the story, and then I'm going to ask him for his thought process. So male patient who actually worked at his hospital, diagnosed with FAP, familial adenomatous polyposis, at the age of 17 and had the required total colectomy, was diagnosed with desmoid fibromatosis at the age of 28, and was found to have an APC loss, not surprisingly. And so if you look at the imaging, you can see this desmoid tumor here, quite extensive in the abdominal cavity, and again, resembling the shape of our famous landmark. So yes, by the guidelines that we talked about, we have some options. And what would be the next steps? Do we think about a watch and wait approach in somebody with FAP? And so Dr. Shofsky, tell me a little bit about your thought process as you met this guy.
Well, the only thing I can say is that he was pretty symptomatic. At this time point when we did this scan, we had seen documented disease progression of this huge mass, and the patient was really eager to start some kind of treatment. The only thing that I could offer was like systemic therapy or compassionate use, tyrosine kinase inhibitor use. The problem was that the symptomatology of this patient was not easy to assess because this patient had prior surgery for his FAP condition, so he had a lot of adhesions, etc. And it's hard to assess what is related to the adhesions and what is related to this growing mass. But we finally decided together to start treatment, and luckily at that point in time I had access to nirogacestat in this registration clinical trial, and the patient was highly motivated joining the study. He's distributing medications in my hospital on a regular basis, on a daily basis.
It's incredible. So yes, so the take home here, again, the reason for the watch and wait recommendations, or at least to consider this, is because of this spontaneous regression rate, which Dr. Shofsky walked us through from the other studies. Again, I think at least in our clinic, it comes down to a shared decision-making process. What's the degree of the symptomatology? What is the risk if the tumor is to continue to grow? Tolerability for treatment, and so I think we have this discussion quite frequently to individualize the care for our patients. So your patient was initiated on nirogacestat and then developed skin toxicity, diarrhea, and aphthostomatitis. And so how often do you feel like you encounter this in your practice as far as limiting the ability to use the drug based on the toxicity?
That's seen quite often, I would say, and a considerable proportion of patients that I started on the standard dose required dose reductions, but luckily most of these patients could be kept on active treatment with this intervention and with the dose reductions. And with a significant decrease in their symptomatology. I cannot recall a patient where I had to stop the gamma-secretase inhibitor due to toxicity.
So yes, these are common side effects. I actually had a patient just this week in clinic who was absolutely traumatized and came to see me because she had these giant lumps in her groin and thought she had contracted a sexually transmitted infection, and so she actually had hidradenitis suppurativa. So these are almost boil-like lesions that are really central to the biology of Notch. We're not entirely clear on the whole pathway. But in addition to your more common drug rash type of thing, macular papular rashes, we certainly want to be aware of hidradenitis. And so shown here are just some recommendations for management. We often will hold drug, potentially let the patient wash out, and then try to re-escalate. And oftentimes that works very, very well. In my clinic, the gastrointestinal toxicity typically has been a little bit less than what was described in the study. It's usually pretty well managed, certainly compared to sorafenib. The diarrhea and the nausea is usually when they're first getting started and sort of equilibrated, but certainly we can use our standard armamentarium to help manage that. So you have a practice aid should you choose. So here's the before and after. So he was continued on 100 milligrams twice daily, again from the toxicities, achieved a partial response after 6 months. This is really beautiful. And then was on for 3 years, it sounds like. And so at that point, again, another dose reduction and was able to wind up getting to a complete response. So this is just incredible, right? So a tumor that's that big that can actually get down to a complete response. So how long do you need to keep these people on treatment?
Well, I just wanted to say that's also the reason why I've not been able to convince this patient to stop treatment. In the absence of reliable data on how long patients should be treated, he didn't dare to stop. Because in Europe, the drug is not approved yet for routine clinical use. So patients on this drug know that if they stop, they may be at risk of not gaining access to a gamma-secretase inhibitor again. In clinical routine, if the drug would be easily available in my country, I guess I would use similar strategies as I have used in the pre-tyrosine kinase inhibitor, pre-gamma-secretase inhibitor era. Typically, patients in that era were treated for a period of 6 to 12 months, I would say. And if I saw the typical imaging changes suggesting a therapeutic effect of the drug or a spontaneous regression, you never know, then I tended to stop if the patients were agreeing with that. But nobody knows how long we have to treat the patient, and the data that you are showing here, Bree, is also strongly suggestion that the quality of the response improves over time. So it's really a difficult question at this point.
Yeah, I think this data was really striking. I mean, yes, the longer patients stay on, the more or the higher the chances are of achieving that RECIST response. But again, does that necessarily matter? Like the RECIST is fairly arbitrary in desmoid tumor. It's a 30% decrease, right? So if you've got a volume change, like is there a particular threshold where it is safe to stop treatment? And I think it really comes down to the patient's comfort, and at least, you know, in the United States now we have it available, and I can take the patient off with a sort of reassurance that it's not going anywhere, that we have access, but totally a different story prior to the drug being approved, and certainly in other countries where it's not. Beautiful response, success story. Lovely.
And of course, the thing on the right side is the liver and not a remaining piece of the tumor.
Yeah, it's right in the same spot. Good to do. Thanks for pointing that out. All right, so our last case that I'll just mention, so this is actually my patient, so 34-year-old Hispanic female, 3 pregnancies, including an emergent C-section in 2021, who noted a left lower quadrant growth in 2024, so about 3 years after her last pregnancy. Biopsy confirmed desmoid with a T41A beta-catenin mutation, came to clinic. By the guidelines, yes, an abdominal wall desmoid could be considered for surgical resection. However, we talked about her in tumor board, and just given the depth of this desmoid and sort of intruding internally and the likely recovery from putting her back together after that, we did not want to do that. So she was interested in talking about treatment for neuro, but she also wanted one more child. So interested in having yet another pregnancy and wanted to think about what that would mean if she started neuro, given the ovarian side effects. So you guys probably know this data, but again, 75% risk of some degree of ovarian toxicity with nirogacestat, changes in hormone levels, clinical manifestations with loss of menses, hot flashes, the whole kit and caboodle. But the take home is, at least in the limited data that we have, most patients, when they come off drug or even while they're still on drug, can have spontaneous return of ovarian function. And so we don't really have great longitudinal data for women that were treated on nirogacestat and had their cycles return and then went on to get pregnant, and how those pregnancies went. So I think there's a lot of unanswered questions here. This is just a snapshot of the data that we do have. Again, small number of patients, most patients with resolution of ovarian toxicity once they come off the drug in being able to return to their normal cycles. But so these are unanswered questions. So how do you approach counseling for a patient who's worried about this? When is the right time for someone to become pregnant? Does everyone need to do egg harvesting or sperm banking in the setting of doing therapy with nirogacestat? Patrick, how do you counsel your patients in some of these things?
Well, the first thing I want to say is the only patients that did not consent to joining the registration trial in my institution were young female patients who wanted to become pregnant. These were 2 or 3 patients that I remember well. We do collect sperm in young male patients undergoing anti-cancer treatment in basically every patient. And we also send our young female patient population to our gynecologist for advice, and they can use all means of fertility preservation that are technically feasible. I'm quite reassured about the reversibility of the ovarian toxicity. I must admit, the data I have seen so far from limited patient numbers is, to me, convincing that things improve over time after discontinuation of treatment. But of course, we don't have the full picture. We don't know whether this will happen in every patient and whether the ovarian function will recover to full functional level at a given point in time. At the same time, I have to admit that I tend to believe that ovarian insufficiency is an on-targeted side effect of active treatments in desmoid tumors. I mean, the drugs that we used in the past have also had an impact on hormonal activity in the body. And we know that we diagnose more desmoid fibromatosis during or after pregnancy. We know that in the past we recommended to all our female patients to stop hormonal drugs, etc. But even here, the evidence is decreasing over time. I remember seeing a few posters at scientific meetings reassuring us that it's not an absolute no-no to use hormones in this patient population. Early days.
Excellent. So she actually did go on nirogacestat. We counseled her with all of these things. She is miserable from hot flashes and mood swings, but has already had a very quick response after only 3 months of treatment. But she's asking me, when do I get to come off? When do I get to come off? Because again, despite managing these things, she's 32, right? Like, this is way early for her to be going through these things, and it's fairly sudden as well. So. All right, so the summary and take home, we'll talk about some questions here in a second. So basically, multidisciplinary management is key. We've hit on the importance and reminded you of active surveillance as a reasonable approach for a subset of patients. If you're contemplating surgery, again, a multidisciplinary discussion, and really the guidelines reserve this for certain selected tumors with low surgical morbidity, or certainly emergent situations, particularly in the setting of FAP, bowel obstruction, those sorts of things. And then we've talked about therapies that are options, particularly, again, in other countries where nirogacestat is not approved, that we do continue to utilize these other agents for therapeutic options. But at this point, niro is the only FDA-approved treatment for desmoid tumors.
We did receive a few questions from our virtual audience, I guess, and also from one or two colleagues here in the room. Maybe we can go through one or two of them.
Yes.
The first question was, after being on active treatment, I guess, with a gamma-secretase inhibitor, what percentage of tumor color changing on MRI should prompt us to stop treatment? What is your position on that, Bree?
It's a great question. I think I felt much more comfortable in the chemo era where I could see, so for example, when I was giving people Doxil, that 3-month scan or the scan after the 4th cycle, you would see part of the tumor starting to become dormant. It sort of tipped over that edge and you were seeing the drop in enhancement. And so that's still reassuring. But I think you don't know 100% how durable that's going to be. And I felt pretty confident once I started to see that with chemo that we were good to stop and the tumor would likely continue to do its thing. But I think with niro, we're not really there yet. We don't have that data to say that for sure. And it seems like that 1-year time point, when you look at the responses, that's most of the patients get to that point by about that year. So I think everything's balanced between side effects and benefits of treatment. But I tell people I'm trying to keep them on for about a year in order to hit most of the target and based on the data that we do have, hopefully that will be less in the future.
Please.
Go ahead. Mm-hmm.
Yeah. Yeah, we actually started doing that after learning that the drug gives primary ovarian insufficiency during the conduct of the registration trial. But thanks for reminding us. Bree, we have other questions. For example, a question about treating adolescent patients with niro. I guess you touched it. There is one important trial with accrual completed, but we're still waiting for the results, right?
Yeah, exactly. So it's fully accrued. The hope is for within the next year that we'll have data from my inside sources, but TBD on what it looks like overall. But I think in adolescence, it's even harder, right? So with this fertility issue, like when we were offering this to adolescent women or, people who are like, I never want to have kids, but you're 16 years old and maybe you're not 100% sure of those things right at that moment. Like you just want to make sure that you cover all the bases and do a thorough counseling there.
And we have a final question from Mark Dixon in the audience, who asks us to make a choice for treating our patients either with sorafenib or nirogacestat, given the fact that both drugs are available on the American market, unfortunately not in other countries at this point routinely. Well, if I had both drugs easily available, I would look at the safety profile of the two drugs. I've been treating a lot of renal cell carcinoma in the past 20 years as well. I'm not only treating sarcomas. I must say I was quite happy when we could replace sorafenib as a drug of choice in renal cell carcinoma after it was introduced in 2005 for that indication because of the pretty impressive cutaneous toxicity, gastrointestinal toxicity, hypertension, thyroid dysfunction, you name it. My experience with nirogacestat is different. I have patients on trial like the one that you showed on treatment for 5.5 years with dose reduction, some fine-tuning of how we treat the patients who can easily live with the drug and are happy with the treatment. So if I would have to make a choice, I think the gamma-secretase inhibitor would be my first choice at this point in time due to toxicity. My absolute first choice is to enter as many patients in clinical trials with even more innovative compounds, maybe from the same, maybe from other classes.
Dr. Adele.
Just a quick comment. Before coming out to ASCO yesterday, I was in clinic and I received notification of an insurance denial because the tumor didn't grow by more than 20%, and specifically because the imaging wasn't within a 12-month time period. So It's coming, so be prepared.
Oh, somebody had asked about the beta-catenin mutation specificity. So, like, is there a particular differential activity? I don't think we have that data as of yet, but if in the subset analysis of nirogacestat, basically beta-catenin and APC mutations were equally effective, I think that plays into those mechanisms of resistance. And I do have a few patients where the niro has not led to that response, and I think that's a group of patients that we really want to study, and maybe some of these signals will emerge with S45F and so on.
But maybe we should all keep our eyes open for drugs directly interfering with
Yes.
beta-catenin. They are coming. There will be data out there in the near future. Can't disclose any details here. But there are drugs which act directly on this pathway, and they might be of interest for patients with desmoid fibromatosis, I assume.
All right, well, with that, it's time for ASCO. Thanks to everybody for sticking around.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partners, the Desmoid Tumor Research Foundation and Sarcoma Alliance for Research through Collaboration. This activity is supported by an independent medical education grant from SpringWorks Therapeutics Incorporated. To access all materials for this activity, visit peerview.com/NVF860.